Hello everybody. Today we are going to discuss about the ESC guidelines for acute coronary artery syndrome, which was published in 2023. So the criteria for myocardial injury. The term myocardial injury should be used when there is evidence of elevated cardiac troponin values with at least one value above 99 percentile upper reference limit. The myocardial injury is considered acute if there is rise or fall of the cardiac troponin values. The term myocardial infarction should be used when there is acute myocardial injury with clinical evidence of acute myocardial ischemia and with detection of rise or fall of cardiac troponin value with at least one value above 99 percentile of upper reference limit or at least one of the following. That is symptom of myocardial ischemia, new ischemic ECG changes, development of pathological Q wave, and the imaging evidence of new loss of viable myocardium or new regional wall motion abnormality in pattern consistent with the ischemic etiology. Then identification of coronary thrombus by angiography or by autopsy. So postmortem demonstration of acute atherothrombosis in artery supplying infarcted artery meets the criteria for type 1 MI. Evidence of imbalance between myocardial oxygen supply and demand unrelated to the acute atherothrombosis meets the criteria for type 2 MI. Cardiac death with symptoms suggestive of myocardial ischemia and presumed new ischemic ECG changes before cardiac troponin value become available or abnormal meets the criteria for type 3 MI. Now, the percutaneous coronary intervention related MI is termed as type 4A MI, and coronary artery bypass grafting related MI is termed as type 5 MI. Coronary procedure related MI less than 48 hours after index procedure is arbitrarily defined as elevation of cardiac troponin more than 5 times for type 4A MI and more than 10 times for type 5 of 99 percentile of upper reference limit in patient with normal baseline values. Patient with elevated pre-procedural cardiac troponin value in whom pre-procedural cardiac troponin levels are stable or falling must meet criteria for less more than 5 or more than 10-fold increase or manifest change in baseline value of more than 20%. In addition with at least one of the following. New ischemic ECG changes, development of new pathological Q wave, imaging evidence of loss of viable myocardium that is presumed to be new or pattern consistent with ischemic etiology, angiographic findings consisting of procedural flow limiting complications such as coronary dissection, occlusion of major epicardial artery or graft, side branch occlusion thrombus, disruption of collateral flow, and distal embolization. Isolated development of new pathological Q wave meets the type 4A MI and type 5 MI criteria with either revascularization and procedure if cardiac troponin values are elevated and rising, but less than pre-specified threshold for PCI and CABG. Other type 4 MI include type 4A MI stent thrombosis, type 4C MI restenosis that both meet type 1 criteria. Postmortem demonstration of procedure-related thrombus meets the type 4A MI criteria and 4B MI criteria if associated with the stent. Any of the following criteria meets the diagnosis of prior or silent or under-recognized MI. Abnormal Q wave with or without symptom in the absence of non-ischemic cause. Imaging evidence of loss of viable myocardium in pattern consistent with ischemic etiology and pathoanatomical finding of prior MI. Patient presenting with suspected ACS may eventually receive diagnosis of acute myocardial infarction or unstable angina. The diagnosis of myocardial infarction is associated with the cardiac troponin release and is based on the fourth universal definition of MI. Unstable angina is defined as myocardial ischemia at rest or minimal exertion in the absence of acute myocyte injury and necrosis. It is characterized by the specific clinical finding of prolonged angina at rest, new onset severe angina, and angina that is increasing in frequency, longer in duration, lower in threshold, or angina that occurs after recent episode of MI. This is the ACS clinical spectrum. So, for clinical presentation, patient can be asymptomatic, patient can have increasing chest pain, persistent chest pain, patient can be in cardiogenic shock, or it can be in assist. It can be in cardiac arrest. ECG changes wise, the finding can be normal, can present as ST segment depression, ST segment elevation, and malignant arrhythmia. And according to the ECG changes and the cardiac markers, the ACS is divided into NSTEMI and STEMI. So if a patient had signs and symptoms suggestive of ACS, then we need to perform ECG within the 10 minutes of first medical contact. And according to the ECG, the working diagnosis can be STEMI or it can be NSTEMI. Then further investigation will be based on HS troponin level, angiography, and imaging. And according to that, the final diagnosis will be STEMI, NSTEMI, unstable angina, or non-ACS diagnosis. So the first medical contact, the time point in when the patient is initially assessed by physician, paramedic, nurse, and the other trained emergency medical services worker who can obtain and interpret the ECG and deliver the initial intervention. So first medical contact can be either in pre-hospital setting or upon patient arrival at hospital. Now, STEMI diagnosis. The time at which patient with the ischemic symptom is interpreted as presenting with ACS or STEMI elevation. Now, a primary PCI, emergent PCI with balloon, stent, and other approved device perform on infarct-related artery without previous fibrinolytic treatment. Primary PCI strategy, emergency coronary angiography, and PCI of infarct-related artery if indicated. Then rescue PCI, emergency PCI performed as soon as possible in cases of failed fibrinolysis. Routine early PCI after fibrinolysis. Coronary angiography with PCI of infarct-related artery, if indicated, performed between 2 hours and 24 hours after successful fibrinolysis. Then pharmacoinvasive strategy, fibrinolysis combined with the rescue PCI or routine early PCI strategy. Immediate invasive strategy, emergency coronary angiography, and PCI and CABG of infarct-related artery if indicated. Then early invasive strategy, early coronary angiography and PCI and CABG of infarct-related artery if indicated. Early means within 24 hours. And selected invasive strategy, coronary angiography, PCI, CABG based on clinical assessment or non-invasive testing. So this is the schematic representation of the ACS presentation. So first thing with that we need to take the ECG, physical examination, clinical history, vital sign, and HS troponin level. And then according to the presentation, if the patient presented with STEMI, then we need to go for immediate angiography, PCR fibrinolysis. If in STEMI, then we need to divide the patient into very high risk features and without very high risk features. If the patient is presenting with the very high risk picture, then we should take the decision of immediate angiography plus PCI. If without very high risk feature, consider angiography within 24 hours. Regarding history taking and physical examination, it is crucial to take the focused medical history and accurately characterize the presenting symptom in order to manage the patient with appropriate care pathway as soon as possible. Prompt assessment of the vital sign is recommended at first medical contact at the same time as acquisition of initial ECG. In patient presenting with the suspected ACS, the physical examination is recommended and is useful both to eliminate differential diagnosis and to identify very high risk and the high risk ACS feature. This may be particularly relevant for patient presenting with cardiac arrest, signs of cardiac shock, hemodynamic and electrical instability. Focused physical examination should include checking for the presence of all major pulses, measurement of blood pressure in both arms, auscultation of heart and lung, and assessing for signs of heart failure and circulatory compromise. Regarding diagnostic tool and ECG, resting 12-lead ECG is the first-line diagnostic tool in the assessment of the patient with suspected ACS. It is recommended that ECG is obtained immediately upon first medical contact and interpreted by a qualified emergency medical technician or physician within the 10 minutes. It should be repeated as necessarily, especially if symptoms have wanted. wind at first medical contact. Based on initial ECG, a patient with the suspected ACS can be differentiated into two working diagnoses. Patient with acute chest pain and persistent ST segment elevation on ECG. Then the working diagnosis is STEMI, and if there are the STEMI or a STEMI equivalent. So the vast majority of this patient will sustain myocardial necrosis, troponin elevation, fulfilling the criteria for MI, but MI will not be the final diagnosis in all patients with working diagnosis of STEMI. So the patient with the acute chest pain but without persistent ST segment elevation on ECG should receive the working diagnosis as end-stage. This patient may exhibit other ECG alteration, including transient ST segment elevation, persistent or transient ST segment depression, T-wave abnormalities, including hyperacute T-wave inversion, biphasic T-wave, flat T-wave, pseudo-normalization of T-wave. Alternatively, the ECG may be normal. The majority of the patients in this category who subsequently display a typical rise or fall in cardiac troponin level will receive the final diagnosis of end-stage. In other patients, the troponin level will remain below 99 percentile and they will receive the final diagnosis of unstable angina. Although with high sensitivity troponin assay, this diagnosis has become less common. It is also important to recognize the NSTEMI or unstable angina will not be the final diagnosis in all patients with initial working diagnosis of NSTEMI ACS. Acute coronary syndrome with the persistent ST segment elevation, that is suspected ST segment myocardial infarction. The priority for this patient is implementation of the reperfusion therapy as soon as possible. In the appropriate clinical context, ST segment elevation is considered a suggestive of ongoing coronary artery occlusion in following cases. That is new ST segment elevation at J point and at least two contagious leaks. More than 2.5 mm in men less than 40 years, more than or equal to 2 mm in men more than 40 years, or more than or equal to 1.5 mm in female regardless of age in leads V1 to V3 or more than or equal to 1 mm in other leads. ST segment depression in lead V1 to V3, especially in the terminal T wave is positive, and ST segment elevation in V5, V7 to V9 is highly suggestive of posterior coronary artery occlusion, often the left circumflex artery. ST segment elevation in V3R and V4R is highly suggestive of ongoing RV ischemia. ST segment depression more than or equal to 1 mm in more than or equal to 6 leads. That is inferolateral ST depression coupled with ST segment elevation in AVR and V1 suggests multivessel ischemia and left main coronary artery obstruction, particularly if the patient present with the hemodynamic compromise. Regarding bundle branch block, in patient with the high clinical suspicion of ongoing myocardial ischemia, the presence of LBB and RBB or pace rhythm precludes the accurate assessment of presence and absence of ST segment elevation. Therefore, patient presenting with this ECG pattern in combination with signs and symptoms that are highly suspicious of the ongoing myocardial ischemia should be managed similarly to those with clear ST segment elevation regardless of whether bundle branch block is previously known. Acute coronary syndrome without persistent ST segment elevation. While the ECG in the setting of NSTEMI ACS may be normal in more than one-third of the patient, characteristic ECG abnormality are frequently present and increase the diagnostic probability of ACS. These ECG abnormalities include ST depression and T-wave changes, especially biphasic T-wave, prominent negative T-wave, that is valence sign related to severe proximal left anterior descending artery stenosis. Recommendation for clinical and diagnostic tool for patient with suspected acute coronary artery syndrome. It is recommended to base the diagnosis and initial short-term risk stratification of ACS on combination of clinical history, symptom, vital sign, and other physical findings, ECG and HS stroke. 12-lead ECG recording and interpretation is recommended as soon as possible at the point of first medical contact with the target of less than 10 minutes. Continuous ECG monitoring and the availability of the defibrillator capacity is recommended as soon as possible in all patients with suspected STEMI in suspected ACS with other ECG changes or ongoing chest pain once the diagnosis of MI is made. The use of additional ECG lead is recommended in case of inferior STEMI, that is V3R, V4R, and V7 to V9, and if a total vessel occlusion is suspected and standard lead is inconclusive. So the additional 12 lead ECG is recommended in cases with a recurrent symptom and diagnostic uncertainty. Now regarding diagnostic tool, high sensitivity cardiac profile. After excluding clinical and ECG sign of STEMI and very high risk of NSTEMI, biomarkers play a complementary role in diagnosis, risk stratification, and management of patient with suspected ACs. So patient present with the suspected NSTEMI without indication for immediate invasive angiography. Then we need to perform the HS troponin at 0 hour, 1 hour, and 2 hours. If the HS troponin is very low at 0, 1 hour, and 2 hour, then the ACS is ruled out. If it is a high serial, if there is a serial increase in HS troponin level, then the diagnosis of ACS can be made. And if the patient do not meet the criteria for either of other two pathway, then and if there is a high suspicion, then we need to keep the patient in the observation. The use of biomarkers other than the cardiac troponin for the diagnosis of ACS is not recommended. Among the multitude of additional biomarkers, evaluate the diagnosis of NSTEMI. Only creatinine kinase, myocardial band isoenzyme, myosin binding protein C, and copeptin may have clinical relevance when used in combination with the standard cardiac troponin. Although in most clinical situations, their incremental value above and beyond cardiac troponin is limited. So it is recommended to measure cardiac troponin with high sensitivity assay immediately after presentation and to obtain the result within the 6 minutes of the blood sample. It is recommended to use the ESC algorithm approach with serial HS cardiac troponin measurement to rule in and rule out NSTEMI. Additional testing after 3 hours is recommended if first two HS troponin measures of 0 to 1 hour algorithm are inconclusive and no alternative diagnosis explaining the condition have been made. The use of established risk factor for prognosis estimation should be considered. Then triage for emergency reperfusion strategy. It is recommended that patients with the suspected stem are immediately triaged for the emergency reperfusion strategy. Now, the non-invasive imaging, echocardiography. In emergency room and chest pain unit, transthoracic echocardiography performed and interpreted by the trained healthcare professional should be routinely available. In cases of suspected ACS with diagnostic uncertainty, TTE can be useful to identify the signs suggestive of ongoing ischemia or prior M. However, this should not result in relevant delay in transfer to cardiac catheterization lab if there is suspicion of acute coronary artery occlusion. TT can be useful to suggest alternative etiologies associated with the chest pain. All patients presenting with cardiogenic shock and hemodynamic instability should undergo emergency TTE to try to identify the underlying cause, in particular to assess LV and RV function and to look for evidence of mechanical complications. Now, regarding computed tomography, upon clinical presentation, the CT is often diagnostic tool of choice for ruling out alternative, potentially life-threatening differential diagnosis of ACS like PE and aortic dissection. Generally, CT doesn't have any role in patient presenting with the suspicion of ongoing acute coronary artery occlusion for whom emergency ICA is priority. Coronary CT angiography has been investigated in many trials for assessment of patients presenting to the ED with suspected NSTEMI ACs. However, the trials investigating CT angio in the era of HS troponin assays may be greater relevance for contemporary practice. The Bacon study showed no reduction of in-hospital duration of stay or hospital admission in CT angiography arm compared with patient investigating with HS troponin, with similar result to those observed in ROMICAT and rapid CTCA trial. Default approach using CT angio as a first line imaging investigation in patient with suspected NSTEMI therefore is not recommended. A normal CT angiography has high negative predictive value to exclude ACS and is associated with excellent clinical outcome. CT, CT angio can also be used to risk stratify selected low risk and STEMI patients. Such a patient who are found to have normal coronary arteries, non-obstructive coronary disease, and distal obstructive disease may then require invasive coronary angiography. Of note, the utility of the CT angio may be limited in patients with tachycardia, established coronary artery disease, previous stent, and the extensive coronary calcification. Now, regarding cardiac magnetic resonance imaging with or without stress imaging. Cardiac magnetic resonance imaging delineates the cardiac structure and function. Also has the ability to provide assessment of the myocardial perfusion and pattern of myocardial injury. The CMR is the imaging test of choice when the poor echocardiographic windows preclude the diagnostic echocardiographic evaluation. CMR allows the direct visualization of infarcted region, providing information on scarring and viability that can be differentiated from the other forms of myocardial injury, that is myocardial infarction. So CMR is therefore particular clinical value in establishing diagnosis of acute myocardial infarction where there is diagnostic uncertainty. So CMR can also be useful in identifying culprit vascular territory and in confirming diagnosis of myocarditis and Takotsubo cardiomyopathy, among the other differentials. So CMR is of particular value in establishing the diagnosis in patient presenting with working diagnosis of myocardial infarction with non-obstructive coronary arteries following invasive angiography, and it is a gold standard for assessment of LV thrombus. So recommendation for non-invasive imaging in initial assessment of patient with suspected acute coronary artery syndrome. Emergent TT is recommended in patient with suspected ACS presenting with cardiogenic shock or mechanical complication. In patient with suspected ACS, non-elevated cardiac troponin level, no ECG changes, no recurrence of pain, incorporating CT angio or non-invasive stress imaging test as a part of initial workup should be considered. Emergency transthoracic echo should be considered at triage in case of diagnostic uncertainty, but this should not result in delay in transfer to cardiac catheterization lab if there is suspicion of AC, acute coronary artery occlusion. Routine early CT angio in patient with suspected ACS is not recommended. Regarding initial management, initial diagnosis and monitoring. Management of the ACS starts from the point of first medical contact when working diagnosis of ACS is established. The working diagnosis of ACS is usually based on symptoms consistent with myocardial ischemia and signs on 12-lead ECG. It is recommended to initiate ECG monitoring as soon as possible in all patients with suspected ACS in order to detect life-threatening arrhythmia and to allow prompt defibrillation if indicated. Then acute pharmacotherapy. Oxygen supplementation is recommended in ACS patient with hypoxemia and is only with hypoxemia. And if the oxygen saturation is more than 90%, then it is not recommended. Then sublingual nitrate may be helpful to relieve ischemic symptoms. However, a reduction in chest pain after nitroglycerin administration can be misleading and is not recommended as a diagnostic maneuver. In patients with the ECG compatible with the ongoing STEMI and symptom relief after nitroglycerin administration, it is recommended to obtain another 12-lead ECG. Complete normalization of ST segment elevation along with relief of symptom after nitroglycerin administration is suggestive of coronary vasospasm with or without associated MI. Nitrate should not be given to patients with hypotension, marked bradycardia, tachycardia, RV infarction, known severe aortic stenosis, phosphodiesterase 5 inhibitor use within previous 24 to 48 hours. For pain relief, intravenous opioids, that is morphine 5 to 10 mg, should be considered for relief of severe chest pain. Other forms of pain relief, that is nitrous oxide, oxygen plus IV acetaminophen, paracetamol, have been reported to be inferior to the morphine. However, morphine may enhance nausea and vomiting, slows the gastrointestinal absorption of oral medicine, which may delay the onset of action of orally administered antiplatelet therapy. Evidence from small scale trials suggested that IV morphine may also reduce the myocardial microvascular damage when given to patients with ongoing acute coronary artery occlusion, though co administration with metoclopramide appear to negate this effect. Uh, Conversely, morphine has been reported to reduce antiplatelet activity after administration of ticagrelor, though this effect was caused by metoclopramide administration. The positive effect of the morphine on myocardial damage may potentially be related to reduced oxygen consumption as a result of decreased free load and negative inotropy and chronotropy. Platelet inhibition induced by oral P2 receptor antagonists may be delayed in patients with ongoing myocardial infarction. Morphine may also reduce the further absorption, delay onset of action, and decrease the antiplatelet effect of oral P2 receptor inhibitor in MI patient, although this effect may vary between different P2 inhibitors. Further research is ongoing in this area, but at present it should be noted that currently available clinical data have not demonstrated any increased risk of adverse clinical outcome as a result of any interaction between morphine and antiplatelet agent in setting of ACs. Intravenous beta blocker. Few RCT has testing early IV beta blocker have been performed in the era of invasive management of patient with working diagnosis of stent. Not all beta blocker appear to exert same cardioprotective effect in the context of ongoing coronary artery occlusion, with metoprolol demonstrating the greatest protective effect in experimental study. Intravenous metoprolol is also most widely tested beta blocker in trial enrolling patient undergoing PCA. While long-term clinical benefit associated with early IV metoprolol administration are not clear, it is safe when used in patients without sign of acute heart failure and has been consistently associated with reduction in the incidence of ventricular fibrillation and microvascular obstruction. Based on this data, IV beta blocker should be considered at the time of presentation in patient with working diagnosis of STEMI undergoing PCI with no signs of acute heart failure, a systolic blood pressure more than 120 mg and without other contraindication. Administration of IV beta blockers in patient with suspected STEMI has not been tested. So recommendations for initial management of patient with ACs. Oxygen is recommended in patient with hypoxemia, that is less than that is O2 concentration less than 90%. Routine oxygenation is not recommended in patient without hypoxemia. Intravenous opioid should be considered to relieve the pain. Mild tranquilizer should be considered in very anxious patients. Intravenous blocker should be considered at the time of presentation in patient undergoing PCI with no signs of acute heart failure, SPP more than 120, and no other contraindication. It is recommended that pre-hospital management of patient with working diagnosis of STEMI is based on the regional network designed to deliver reperfusion therapy expeditiously and effectively with effort made to make PCI available. It is recommended that PCI capable center deliver 24-hour service and are able to perform PCI. It is recommended that patient transfer to PCI bypass emergency department CCU and transfer directly to catheterization lab. It is recommended that EMS transfer the patient with suspected STEMI to PCI capable center bypassing the non-PCI center. It is recommended that the ambulance team are trained and equipped to identify ECG pattern suggestive of acute coronary occlusion and to administer initial therapy, including defibrillation and fibrinolysis. All hospital and EMS participating in the care of patient with suspected STEMI record and audit delay time and work together to achieve and maintain quality targets. Then acute phase management of the patient with acute coronary syndrome. Selection of invasive strategy and reperfusion. Depending on the initial assessment of the ECG, the clinical context, and the hemodynamic stability, patient with suspected ACS should be classified as either patient with working diagnosis of STEMI. This patient should be triaged for immediate reperfusion therapy, that is PCI strategy and fibrinolysis. PCI is not possible within 120 minutes of diagnosis. Patient with working diagnosis of NSTEMI. For this patient, inpatient invasive strategy is recommended. Immediate invasive strategy is recommended when any high risk feature is present. And early, that is within 24-hour invasive strategy, should be considered when any high risk features are present. Now, the acute coronary artery syndrome managed with the invasive strategy. Invasive strategies are time sensitive. It is recommended that patient triage to immediate invasive strategy or NSTEMI with very high risk characteristic receive emergency angiography as soon as possible. High risk NSTEMI patient that is means those who showed the serial rise in HS troponin level in 1 and 2 hour interval, dynamic ST and T wave changes with transient ST segment elevation with grace risk score of more than 140 should be considered for early invasive strategy, that is within 24 hours. Now, primary percutaneous intervention for for STEMI in patient with working diagnosis of STEMI, PCA strategy is a preferred reperfusion strategy provided it can be performed in timely manner, that is within 120 minutes of ECG based diagnosis. RCT have shown that if delay to treatment is similar, then PCI is superior to fibrinolysis in reducing mortality, non-fatal reinfarction, and stroke. However, in some circumstances, PCI is not immediately available, and fibrinolysis should be initiated expeditiously as a part of pharmacoinvasive strategy, provided that patient has presented within 12 hours of symptoms. There is a lack of contemporaneous data to inform treatment delay limit, at which advantage of PCI over fibrinolysis is lost. For simplicity, absolute time of 120 minutes from STEMI diagnosis to PCI-mediated reperfusion rather than relative PCI-related delay over fibrinolysis has been chosen. Given the recommended time interval of 10 minutes from STEMI diagnosis to administration of bolus fibrinolytic, the 120 minute, the absolute time delay would correspond to relative PCI-related delay in the range of 110 to 120 minutes. This is within the range of the times identified as a limit of delay below which PCI should be chosen in older studies and registries. For patients who undergo fibrinolysis, rescue PCI is indicated if fibrinolysis fails. That is, ST segment resolution less than 50% within 60 to 90 minutes of fibrinolysis, or in presence of hemodynamic and electrical instability, worsening ischemia, and persistent chest pain. Patient with successful fibrinolysis should undergo early invasive angiography, that is within 2 to 24 hours from the time of lytic bolus and injection. Patient with working diagnosis of STEMI who presents with the non-PCI center should be immediately transferred to PCI capable center. If PCI is not feasible within 120 minutes, then the patient should undergo immediate fibrinolysis followed by transfer to PCI center without waiting for signs for reperfusion. For patient presenting after 12 hours from symptom onset, PCI strategy is preferred over fibrinolysis in all cases. Emergency coronary artery bypass grafting surgery should be considered for patients with patent infarct-related artery but with unsuitable anatomy for PCI, either large myocardial area at geopathy or with cardiogenic shock. In patients with MI-related mechanical complication who require coronary revascularization, CABG is recommended at the time of surgical repair. So this is the presentation of uh, uh, presentation pathway, a presentation which is indicating the pathway to the invasive management and myocardial revascularization. If the patient is presenting with the symptoms suggestive of ACS and the ECG is consistent with the STEMI, and then mode of first medical contact should be uh, patient patient by self present to the hospital, or patient might call the EMS. So if the patient is presenting to the PCI related center, then it is suggested that the aim should be less than 60 minutes to the wire crossing. And if the patient is presenting to the non-PCI related center, then and if the PCI is possible, then we need to see that if the PCI is possible in less than 120 minutes. If yes, then we need to refer the patient to PCI center or primary PCI center, and the aim should be less than 90 minutes to wire crossing. If the patient is not presenting to the PCI center within 120 minutes, then we should initiate fibrinolysis. The time of the fibrinolysis should be less than 10 minutes, and then we need to transfer the patient to the PCI related center. Now, the invasive strategy in stable patient with persistent occlusion of infarct-related artery 3 to 28 days after MI, large occluded artery trial, that is OAT trial, report no clinical benefit from routine coronary intervention with medical management in comparison to medical management alone. A meta-analysis of trial testing with the late recanalization of occluded infarct-related artery is beneficial, also showed no benefit of rebirth. Therefore, routine PCA of occluded infarct-related artery in STEMI patient presenting more than 48 hours after symptom and without persistent symptom is not indicated. Now, the immediate invasive strategy for NSTEMI. Immediate invasive strategy refers to the emergency angiography and PCI if indicated, and should be performed in very high risk criteria. That is hemodynamic instability or cardiogenic shock, recurrent or ongoing chest pain refractory to medical treatment, acute heart failure presumed secondary to the ongoing myocardial ischemia, life-threatening arrhythmias and cardiac arrest after presentation, mechanical complication, recurrent dynamic ECG changes suggestive of ischemia. Then routine versus selective invasive strategy. A routine invasive strategy with inpatient coronary angiography is recommended for patients with confirmed diagnosis of NSTEMI or working diagnosis of NSTEMI ECS and high index of suspicion for unstable angina. The available evidences indicate that routine invasive strategy does not reduce all-cause mortality risk in overall population of NSTEMI SCs, but reduces the risk of composite ischemic endpoint, particularly in high-risk patients. So, a routine invasive strategy can increase the risk of periprocedural complication and bleeding. Early versus delayed invasive strategy for NSTEMI. Early invasive strategy refers to the routine invasive angiography within 24 hours of the presentation. This should be considered in patients with working diagnosis of NSTEMI and any of the following high-risk criteria. Confirmed diagnosis of NSTEMI based on the current recommended ESC cardiac troponin algorithm, dynamic ST and T wave changes, then transient ST segment elevation and grace risk score of more than 140. So this is the algorithm of showing management of NSTEMI. Those who presented with the very high risk should taken for the immediate invasive strategy. The very high risk features include hemodynamic instability, cardiogenic shock, recurrent ongoing chest pain, refractory to medical treatment, acute heart failure, life-threatening arrhythmias and cardiac arrest after presentation, mechanical complications, recurrent dynamic ECG changes suggestive of ischemia. If the patient presents to the high risk patient, then early invasive strategy should be done, and it has a class 2A recommendation. This includes confirmed diagnosis of NSTEMI based on ESC algorithm, grace risk score more than 140, transient ST segment elevation, dynamic ST segment and T wave changes. If the patient is in the non-high risk category, then we need to carry out the inpatient invasive strategy. And in patient without high risk or high risk features and low index of suspicion for unstable angina, then we need to go for selective invasive strategy. Now regarding fibrinolysis and pharmacoinvasive strategy, patient with ST segment elevation, infarction. Benefit and indication of fibrinolysis, that is fibrinolytic therapy, is an important reperfusion strategy for STEMI patient presenting within 12 hours of symptom onset when PCI cannot be performed in timely manner, and it prevents 30 early deaths per 1000 patient treated with 6 hours of symptoms. The largest absolute treatment benefit is seen among those patients at high risk, including elderly. Successful reperfusion is generally associated with significant improvement in ischemic symptom, more than 50% ST segment resolution, and hemodynamic stability. Now, the pre-hospital fibrinolysis. If trained medical and the allied health staff can interpret ECG on site or transmit the ECG for remote interpretation, it is recommended to initiate fibrinolytic therapy in pre-hospital setting. A fibrin-specific agent, that is tenecteplase, altiplase, retiplase, is preferred agent. The goal is to start fibrinolytic therapy within 10 minutes of STEMI diagnosis. Fibrinolytic therapy initiation should not be delayed by waiting for the result of cardiac biomarker testing. In meta-analysis of 6 randomized trials, pre-hospital fibrinolysis compared with in-hospital fibrinolysis reduced early mortality by 17%, particularly when administered in first 2 hours after symptoms. The STREAM trial demonstrated that pre-hospital fibrinolysis followed by early PCI strategy was associated with similar outcome to transfer for PCI in STEMI patient presenting within 3 hours of symptom onset who could not undergo PCI within 1 hour of FMC. Although slight excess of intracranial bleeding was observed with investigational strategy. The excess in the intracranial bleeding was blunted by halving the dose of tenecteplase in patients with less than more than 75 years of age. Angiographic and percutaneous coronary intervention after fibrinolysis. It is recommended that the patient should be transferred to PCI center immediately after initiation of lytic therapy. In case of failed fibrinolysis or evidence of reocclusion or reinfarction with recurrence of ST segment elevation, immediate angiography and rescue PCI are indicated. In setting of readministration of fibrinolysis is not beneficial and is discouraged. Even if it is likely that fibrinolysis is successful, that is ST segment resolution of more than 50% at 60 to 90 minutes, typical reperfusion arrhythmia, and disappearance of chest pain, a routine early angiography within 2 to 24 hours is recommended. So the reperfusion therapy is recommended in all patients with working diagnosis of STEMI and symptom of ischemia less than or equal to 12 hours. PCI strategy is recommended over fibrinolysis if anticipated time from diagnosis to PCI is less than 120. If timely PCI cannot be performed in patient with working diagnosis of STEMI, fibrinolytic therapy is recommended within 12 hours of symptoms. Rescue PCI is recommended for failed fibrinolysis. That is ST segment resolution less than 50% within the 60 to 90 minutes of fibrinolytic administration or in presence of hemodynamic or electrical instability, worsening ischemia and persistent chest. In patient with working diagnosis of STEMI and time from symptom onset more than 12 hours, PCI strategy is recommended in presence of ongoing symptom suggestive of ischemia, hemodynamic stability, and life-threatening arrhythmia. A routine PCI strategy should be considered in STEMI patient presenting late, that is 12 to 48 hours after symptoms. A routine PCI of occluded infarct-related artery is not recommended in STEMI patient presenting more than 48 hours after symptom onset without persistent symptoms. A transfer to PCI capable center is recommended in all patients immediately after fibrinolysis. Emergency angiography and PCI of infarct-related artery, if indicated, are recommended in patients with new onset or persistent heart failure and shock after fibrinolysis. Angiography and PCI of infarct-related artery, if indicated, is recommended between 2 to 24 hours after successful fibrinolysis. Invasive strategy in NSTEMI. Invasive strategy during hospital admission is recommended in NSTEMI patient with high risk criteria. A selective invasive approach is recommended in patients without high risk or high risk NSTEMI ACS criteria and with low index suspicion for NSTEMI. Immediate invasive strategy is recommended in patients with working diagnosis of NSTEMI ACS and with at least following very high risk criteria. That is hemodynamic instability, recurrent refractory chest pain, in hospital life-threatening arrhythmia, mechanical complication of MI, acute heart failure, recurrent dynamic ST T-wave changes. Early invasive strategy within 24 hours should be considered in patient with at least one of the following high-risk criteria. That is confirmed diagnosis of NSTEMI based on current recommended ESC HS troponin algorithm, dynamic ST segment T-wave changes, transient ST segment elevation, gray score more than 1. Thank you guys.